Okay, so welcome everyone. Thank you so much for taking the time to join us today. I'm very excited because I know we have an amazing webinar planned for today by Dr. Aguilar, so I'm excited for that. Next slide, Brittany. So just a quick agenda. So we're going to go through like a welcome and then any announcements in our meeting schedule. And then we're going to talk about PCBH SIG leadership. And then we'll talk briefly about the webinar and I'll give it over to Dr. Aguilar and then we'll go through the closing remarks. Next slide, please. So again, welcome. Thank you all for joining us today. And if you're new here, welcome again. And if you're new, there's a couple ways that you can join the PCBH SIG. So if you're new, send your name, affiliation, and email to Samantha Kettle at that email right there, or you can go to our website and click here to join the SIG. And then if there's any job postings that you're looking for or any of the latest information on integrated care, you can go to integratedcarenews.com. And if you have any job announcements that you want to drop for today, you can always put those in the chat to let us know. And then if you want to send a message to the PCBH SIG members and all the other CFHA members, email us at cfha@gaggle.email. And then keep an eye out on our newsletters. They're posted a day before the webinar. So Dr. Houston just sent out our newsletter yesterday. So take a look at that. And then next slide, please. So this is our leadership for the year. So I never introduced myself. My name is Sierra. I am the PCBH SIG student rep this year, and we have a wonderful leadership committee this year. So we have Dr. Gibson Lopez and Dr. Houston, they're co-chairs of the SIG. And then we have Megan Fondo, and then we have Samantha Kettle, and we have Rosemary Hale. So that's what our leadership looks like for this year. Next slide, please. And then this is our meeting schedule for the year. So we've already had 2 meetings, and that is including today. So our first meeting was April 5th. And today we are talking about implementing the PCBH model in the context of severe mental illness. So a super interesting topic. And then we have 3 more meetings for the year. So we have a meeting on August 2nd, and the topic of that meeting is the marriage checkup in primary care. And then we are also having a meeting at the CFHA conference, and that one's going to be super cool. We're going to do a Meet the Mentor meeting, so stick around for more information on that as we get closer to the conference. And then our last meeting will be December 6th, and the topic will be URM mentorship. Next slide, please. And then we also have an exciting new task force leadership here for the Serving Latinx Populations in Primary Care Behavioral Health. And they have a really cool upcoming webinar pretty soon here. So Wednesday, June 29th at 3 p.m. And then this webinar is going to be over training in integrated primary care as bilingual behavioral health students and trainees. So keep an eye out for that and mark your calendars for that awesome webinar. So next slide, please. And then a little plug for being a mentor. So we have a really great opportunity for mentorship. So we have kind of 2 ends here. So if you're interested in receiving mentorship, shoot Rosemary Hale on sidey@gmail.com an email. She's really great at getting people connected. And then if you're interested in being a mentor, I think Dr. Houston, if you can drop our little form link in the chat box, just complete this form and then we'll get you connected with a mentee. Next slide, please. So I am about to turn it over to Dr. Aguilar to talk about implementing the PCBH model in the context of severe mental illness. And just a little bit of a background on Dr. Aguilar. So she is a licensed clinical psychologist and behavioral health consultant in primary care at the Center for Healthcare Services. She also serves as the director of psychology and training at CHCS, a community behavioral health organization that serves as the local mental health authority for Bexar County. She holds dual appointment as an associate professor at the Long Medical School at UT Health San Antonio in both the Department of Psychiatry and the Department of Community and Family Medicine. Dr. Aguilar supervises and trains psychology residents, doctoral level students, and other interns in primary care psychology. So I will turn it over to her.
Thank you so much, Ciara. Let me see if I can share my screen. Thank you for that. I'm very excited to be with you today. Can you all see that? Did that work? Okay, perfect. So today we're going to be talking about implementing the PCBH model in the context of severe mental illness. This is something I've been doing for the last few years. And if you're interested, before I forget, I want to make sure that everybody knows we are hiring. So if this sounds like very fascinating to you, please hit me up. Okay, so let's see. Today, the hope is that you will learn at least 2 vital contextual factors to consider when using the PCBH model with patients who have severe mental illness. And then I have a few tips and tricks that can be very helpful to folks when you're trying to implement this model with patients that have severe mental illness like schizophrenia, and then identify at least 1 intervention strategy. And although we have like 2 and 1 numbers, there's lots of information to gain from this particular presentation. I hope I can get through everything. So I thought what we would do is like funnel in. We're going to kind of start with the larger context of the organizational system where most patients with severe mental illness are served. So my sense is that potentially if there are BHCs on here that are interested in this coming to this presentation, it's because they might be serving patients with severe mental illness. And it's really important to understand the context of where they're receiving services and the kind of services that they're already getting. So you can kind of understand what questions to ask and what variables are relevant as you do the work with them. And then we're going to kind of funnel down into tips and strategies that are helpful with the larger treatment team with primary care. I call it primary care plus. So primary care and psychiatry. And then going specifically to the work that occurs with patients one-on-one in the exam room. So, in the world of community behavioral health, obviously, we are treating patients with severe mental illness, and that typically consists of people of our providers providing medication. Sometimes there's counseling, care management, employment support, and housing support, substance use treatment. And the specific population that we're going to focus on, and I'm not going to spend a lot of time defining all of this, but most people, I think, have a understanding that severe mental illness means schizophrenia or schizoaffective disorder, bipolar type. I can tell you from some of the data we run in our clinic, that's our most common patient is a Hispanic male that has schizoaffective disorder, bipolar type. So we're used to managing those kinds of symptoms and issues in our primary care visits, major depressive disorders, bipolar disorders, and a lot of time, there's a lot of PTSD that is co-occurring and substance use disorders as well. So this is kind of like that therapeutic organizational system. And most patients now across the nation are being served in CCBHCs. And so you probably have heard that term, but in case you haven't, this CCBHC model stands for the Certified Community Behavioral Health Center. And they are required to provide 9 services. These services in blue up here are what is required to be served by the entity. And these services down here at the bottom are actually services that can be delegated out to another entity. In our particular case, almost all of our services here at the center, we are a CCBHC, a certified community behavioral health center, and we have all of these services in-house. So, you, depending on where you're located across the country, you may want to figure out who is your local CCBHC and are the patients that you are serving in your primary care connected to your CCBHC or not. Maybe some of you are embedded in the CCBHC like me. I'm still on the lookout. If anybody is doing that kind of work, please let me know. So the CCBHC model is really aligning financing with the ideal clinical care model, and it's focused really on person-centered treatment, care coordination, and integration, evidence-based practices for serving our patients with severe mental illness, which includes the 24/7 crisis response, flexibility to deliver support outside the 4 walls as well. What's been great is that our particular primary care has been embedded inside a CCBHC. And so you'll hear me speak from that perspective, but I'm also hoping to provide information to those of you that might have to coordinate with your CCBHC externally. So care coordination is the linchpin of the CCBHC. And I mentioned that because the takeaway that I want you to have is that one should, as a BHC, or if you're in a primary care that's external to the CCBHC, to please find the person that's helping your patient coordinate their care. That might be a care manager, it may be a care coordinator, but that person could potentially be so valuable in helping you get the information you need to serve your patient well in primary care. So care coordination is a huge piece of what we do here at CCBHCs. Now, I'm coming from Texas. We're in San Antonio, Texas, and every state is different in terms of the way their CCBHC is set up and the kinds of state-approved interventions and practices that are being implemented in your CCBHC. This is an example from Texas, and it's probably very similar to what other people are doing, but it's not exactly the same. For example, here in our particular county, our CBT is very, very focused, and a very small proportion of our patients actually receive counseling services. You would think that all of our patients get counseling services, but in our particular center, just given the needs and resources across the state, we actually, just a small proportion of our patients do see a counselor for ongoing, weekly CBT treatment. So it is really important to try to figure out what kind of services your patient is being embedded in when you are consulting with a CCBHC or a patient with SMI. So, like I said, there's kind of this wraparound service. There is a big team that's associated with the particular patient that you might be seeing. I would be interested to know, like I said, if people ever get to talk to parts of the care team. This is a key piece, and I always kind of include this slide whenever I talk about the services we do here, because there's the patient in the middle that's getting all of these services potentially around them. And then there's all these people in addition to that the patient has to know and understand and trust. And sometimes that can be a very big team. So I have kind of a little strategy for how we help manage that in our particular center. These are some of the evidence-based treatments for patients that have schizophrenia. And I mentioned them so that you understand that the patient that's coming into primary care, and you might be helping them with their diabetes, they may also be working with their care manager on getting going through our supported employment program, trying to get a job, trying to make a resume. They might be involved in cognitive behavioral therapy already. They might be doing some skills training. They might be involved in a token economy in their group home. There's a lot of things that might already be happening, and having that context sometimes is very important, depending on where the patient is in their system. And so sometimes that might be happening externally, and then sometimes it might be happening, like I said, if you're embedded. I see a hand raised. I guess.
Do you want me to wait? I just have to leave before your presentation's over.
Oh, that's okay. You can pipe in.
Okay, just real quick. So hi, I'm from Oregon, Portland, Oregon, and I'm the Integrated Behavioral Health and Addictions Manager for our 18 primary care clinics through the county. And I guess my initial question is the goal to continue to support these individuals as they access medical treatment, or is the goal to eventually transition them to an outpatient mental health provider if that's not or being provided to them right now? And is that the role of the BHC or BHP? And then lastly, is there any specific support provided specifically to individuals being discharged from psychiatric facilities or mental health hospitals?
Yeah, so I think I saw also a similar comment that I was kind of reading in the chat while you were asking the question. So I think it depends on what your organization's goals are in terms of the role of the BHC. So ideally, a patient that has a severe mental illness like schizophrenia, bipolar disorder, would be connected to their CCBHC for ongoing treatment and care and for stabilization. In our particular center, we have levels of care. So somebody might get a lot of intensive services at first and then move down once they're more stable in care, and still get periodic treatment, but it's not as intense. So I think it depends on what your state looks like and what your local community resources are. The information that I am providing is really on how to help a patient. If you have a patient that has schizophrenia, schizoaffective disorder, bipolar disorder, and they're coming into your exam room and your primary care provider is treating them for diabetes, hypertension, high cholesterol, and you're trying to figure out, okay, what do I do? So I'm trying to give you a sense of, well, this is these are some of the resources that are out there and that exist. So ideally, you could connect them to the CCBHC if they exist in your area and if they're close enough. But if they don't, then it really is trying to help configure perhaps some resources to help them get the resources that they need. I think a lot of that, like I said, depends on your organizational and unit goals, right? Like how far should the BHC go in terms of becoming that care manager or care coordinator? For us, we have very clear roles because we have this network of infrastructure around us already. I don't know if that makes sense. Ideally, the patient would continue in primary care, managing their chronic medical conditions, and continue in psychiatric treatment as well. And that would have to be kind of ongoing. Many primary care providers really don't feel comfortable managing schizoaffective disorder or the medications related to that. And I'm going to talk about that actually in a little bit. So maybe we can kind of move. Typically, there's some literature out there that talks about enhanced primary care and some of the things that are needed for a medical home for patients with severe mental illness. One, and most importantly, is they probably need some additional time and care, and the BHC kind of be included in that. There needs some specialized training for the team. It's kind of what we're trying to do now is help patients or help clinicians understand what might be needed if you're going to serve somebody with schizoaffective disorder. And then structured and planned communication. There really needs to be some carved out time to discuss goals and treatments for patients that are so complex. Part of what we know, and again, part of one of the major takeaways I wanted everybody to understand from our presentation today is that health behaviors are such a key piece of helping patients manage not only their physical and chronic medical conditions, but also helping them manage their psychiatric illnesses. So many times if a patient has a diagnosis of schizophrenia, schizoaffective disorder, they're taking a second-generation antipsychotic. And in those particular cases, we really need to emphasize staying active, eating healthy, avoiding alcohol, avoiding recreational drugs, and quitting or reducing tobacco use. And so that's the perfect entree for BHCs to start their work, even if you have nothing else to work on, which typically isn't the case. You have a million things to work on. So I just wanted to kind of put that out there. So when you have a patient, this is kind of the wellness stuff. When you have a patient that's coming in that has one of these severe mental illness diagnoses, they're typically on an SSRI or a second-generation antipsychotic, some kind of mood stabilizer, and sometimes all classes of these sorts of medicines. And that's important to note because as you review somebody's medication list, you might see some of these names that I'm going to, talk about in a minute. But one of the things that is also important to know is that many patients with positive symptoms that might have active psychosis, thought disorganization, they respond partially or sometimes not even at all to psychotropic medication. And sometimes it takes time for that medication to work. So you may see somebody that appears very disorganized or is still actively hallucinating, but that might be already while they are already on a medicine. And so again, part of what I believe it really is our job is to help our patients manage their health condition in spite of still having some active symptoms. I mean, ideally, we could get to a place where patients would have no symptoms, active psychosis, but that really isn't the reality just yet. Some people have a very positive response to their medications, but it's not always possible. The other issue to remember is that functional improvement does not always follow symptom improvement. And that's really key to remember. So even if a patient does get a lot of remission of all of their psychiatric symptoms, no more auditory hallucinations, no more delusions, their functioning doesn't necessarily improve as well. And that's really where the behavioral intervention or the behavioral activation or the things that we do can really come into play. And I mean, the other thing, because of some of the side effect profile, is that there's a lot of medication non-adherence. And again, that's a big BHC issue that we can always address. So when you have a patient come in from into your primary care, if you see any of these potential medicines on their medication list, as the nurse is collecting that information, please know that some of these and many of these particular second generation antipsychotics are long-acting injectables, and that's what that particular acronym is, LAI. And that's important to know because LAIs come in different intervals. And this is actually something we monitor fairly closely in our particular clinic, because we've noticed that the timing of the visit with primary care, if it can occur in the middle of that long-acting injectable cycle, then we're typically able to get the patient that's a lot more clear, that can understand information more, and can give us more information if we're in that middle interval. So some of the most typical, I guess, intervals for long-acting injectables is every 3 months. So we can get them in month 2 and have them come into their primary care visit during month 2. We typically have a great visit, and the patient is attending to us. They're not distracted. They're not as irritable. The symptoms are managed well. And so we can really work on something behavioral with them. So that's kind of a nice benefit. The other thing is we know that the second generation antipsychotics make folks more vulnerable to metabolic side effects like weight gain, high cholesterol, high blood pressure, high blood sugar. So again, it's a perfect place for BHCs to intervene and really try to make a difference in terms of their health behaviors. There's also some more serious side effect profiles. I just kind of listed them, but I'm not going to have time to go into them. So the question that I want you all to be able to ask is, if a patient is enrolled in services in their CCBHC, is, do you know the name of your care manager? Do you know how often you get to see them? Are you in counseling right now? Are you in therapy? Are you doing CBT? If you're worried about a patient being bored, boredom for our particular population is very high, but boredom is also predictive of relapse. So when you think about some of the interventions that we are doing, it's really important, or if we're trying to find them a job or help find meaning in their lives, sometimes supported employment is the best kind of intervention because it helps with everything else. And then again, asking about the interval for their medicines and if they get injections. The injections really were such a gift for medication adherence, because it obviously helps patients stay adherent to their medicine, to their antipsychotic medicine, for 3 months at a time, which is great. Moving right along. You really want to know if there is ongoing treatment. And in the case of folks that are maybe not already connected, the CCBHC model, if you do have a CCBHC model around you, the spirit of the model is that there is no wrong door. A patient can access services either through entering through substance use treatment, entering through psychiatric services. Sometimes if they are veterans, they have a easy entry into our particular CCBHC services. So again, that's kind of the easiest answer for those of you that are maybe in more rural or remote areas. We would have to get more creative about how to connect folks to ongoing services. And of course, you can feel free to contact me about it. Okay, so moving into the process-oriented tips. One of the things that we have found, and this is kind of, let me go back here. This is kind of trying to focus on these two realms. So we kind of reviewed the therapeutic organizational system, and now thinking about the larger, the primary care team, but also maybe the psychiatric teams. What are some things that we can do to kind of help create an impact on our primary care visits as a BHC serving a patient with SMI? So one thing is to please huddle with your primary care team. And a lot of you probably already do that. But if you know there is a patient that has bipolar disorder with psychotic features that is coming in, then you might want to prioritize. What is the most important thing, primary care provider? What's the bottom line goal that we need to do today? Is it diabetes or is it the cholesterol? Is it that we need to make sure they're just tracking, or is it their blood sugars, or is it just the taking the medication adherence of their metformin every day? Those kinds of things, you want to do all those things, right, with patients that have diabetes, but for patients that have severe mental illness, it's really important just to find that bottom line and have everybody target that same goal. It makes things easier. And it makes it a visit more successful. It makes the patient more successful. The other thing is we've kind of come up with this process here at the center which I call concentering our visits. So there has been, over time that I've been here, we've noticed that there are patients that have to see the BHC first so that they can talk about all their stresses, all of the different issues, all the difficult physical ailments that are happening, all of their physical pain problems, and then we can kind of help the patient target what they actually need to focus on with the PCP. And so there are, like I said, it's like a subset of our patients that we already know, and the patients already know. I'm going to see Dr. Aguilar first, and then I'm going to see my primary care provider, because Dr. Aguilar helps me organize my thinking and helps me figure out what it is I really need from the visit today. And so we have found that to be a really nice way of helping make the PCP much more efficient. Sometimes if the PCP has to get the whole entire story, they're spending a lot of time and having to sort through all of that. When I can sort through it all and figure out, okay, I think this is the most important issue, and then offer the patient over to the primary care provider, it helps create a lot more efficiency. And then the other thing, which was mentioned earlier, is that it's really important to talk about interdisciplinary team meetings and have a time to carve out time, weekly, monthly, where the primary care provider and the team can talk about some of the really important issues that need to be discussed regarding our complex cases. And then we also actually have our psychiatric providers join this meeting because we have that kind of forum inside. We're embedded inside our CCBHC, so we get that interdisciplinary team function, and it's really, really great. But that's another really important part of having a meeting to discuss these things. We have also found, like I said, there's a lot of people that are around a patient, and patients get really confused. Like, wait a minute, you're the doctor that does what? And you're the doctor that does what? So we actually provide patients with a care team map. And I have done this several times for patients that say, okay, your primary care provider is Dr. Morgan, and she provides you with your medicine for your statin, your atorvastatin, and your high blood pressure medicine, your amlodipine. You also see Dr. Womack, and that is your psychiatrist, and they provide your Risperdal and your Abilify. And I'll kind of write those things on there so that the patient understands, like, oh, this doctor's for that, this doctor's for that. This is the care manager, and she goes out to your house and visits you. And I'm the BHC, and I help you with your health behaviors. And this is the nurse that kind of sees you as well. So I actually have an example of that. And if you see me present, you might have seen this before already. So I tried to kind of fill that out for folks. And even though you aren't at this, if you're not at the CCBHC, if you know who these people are, it can kind of help the patient put everything together so that they understand what's happening. Anything visual and concrete is typically pretty helpful for folks. As I said, scheduling the PCP visit in the middle of the LAI cycle is also really helpful. Constantly assessing the window of tolerance. We know that a lot of our patients that have severe mental illness have some cognitive impairment and what I would call sometimes limited mental endurance to keep their sensorium clear and to keep their ability to interact clear as well. And so what we know is that sometimes we have 5 to 15 minutes to get all the information, the key pieces in there. And so we are always looking for what is that window of tolerance for the patient. At some point, they get very overwhelmed and can't really take any more in. So we try to be as quick and as efficient as possible with our visits. I also encourage folks to use closed-ended questions and to do a lot of drill and practicing, kind of talking about what I need to say and then asking the patient what they understood, having them say that back to me. And then at some point I'll do it again. I usually try to do it 3 times in a visit. If there's something important about, even if you are feeling, even if you don't have any symptoms, I still need you to take your medicine every single day. And so at this point, I wanted to call on my resident, Lynette, who has had, she was new to working with SMI folks, and I wanted her to kind of talk about some of her experience in learning how to adjust with our patients in primary care.
Yeah, so I feel that it's important to, again, utilize or leverage the closed-ended questions, especially, when working with patients that are dealing with active psychosis in primary care. So for example, I had a patient about a couple of months ago. He was in the clinic, active delusions, and the PCP wanted me to assist him with medication adherence. So what example of closed-ended questions could be something as simple as, have you taken your medications yesterday? Yes or no? Do you have a pill box as a reminder, for the medication? Something along those lines. It's really important to make sure, especially when you're dealing with patients with active psychosis, that you're funneling in, sort of that information within that short time frame of 5 to 15 minutes. And like Dr. Aguilar said, drill and practice is very helpful. So they can have, an idea of, what is the next steps for the next BHC visit.
Thank you, Lynette. Thank you for that. Lynette has really been so helpful in helping us, and helping me, as we do our visits. And I think it's been eye-opening to her to say, like, okay, this is how we do it, and this is what, what we need to do. And so the drilling and practice can sometimes feel, I think most BHCs and clinicians step away from that a little bit because it feels like you're teaching, it feels repetitive, or maybe condescending, or can feel condescending. But in my experience, again, depending on your approach and depending on your stance, it's actually very helpful to folks. And I've had a lot of people say, thank you so much for helping me remember that, which actually kind of gets into our next piece, which is that, our intervention strategy. So when you're in the room with your patient with SMI, like, what exactly do we need to do, especially if the patient is actively psychotic or struggling in some way, is manic? How do we help center them? Can we even have a visit? But I guess my big thing, what I'm always talking about to trainees and to people that visit the clinic, is that we expect our patients, we expect the patient that comes to us to remember to take their oral medicine for psychosis, to take their metformin for their diabetes, to check their blood sugar in the morning, to go to bed at the right time, to not eat a lot of carbs. We're expecting them to remember all that. And if we have a hard time sorting through all the complexity of their particular story, imagine how hard it is for them. So I do really feel like, it really is, the impetus is on us to help them figure that out. They are leaving, their diabetes doesn't go away because they are actively psychotic. We have to help them manage it no matter what. So this is part of the stance that I was talking about. It's very important to know, and there's been kind of a lot of documented history, that most patients that have schizophrenia, that have hallucinations, delusions, have this experience of feeling very inadequate, of feeling a lot of shame, a lot of guilt, and there's a lot of discomfort with uncertainty. They want clarity. They want things to be black and white, which is sometimes, and you can kind of see that in the behavior change and in some of the ways that they tend to solve problems. And then tolerating distress is very challenging because of the severity and intensity of the distress that they're experiencing. So I guess the other thing I guess I would share with you is that even if you don't really know what to do in a visit with somebody that's very psychotic or very manic, I want you to remember these things, because if you can take the approach, like, how would you approach somebody that had a lot of shame? How would you approach somebody that felt very inadequate? You would be very gentle, you'd be very kind, you'd be very polite, you'd be very respectful. And just taking that stance and thinking about those things as you walk in, I think is so key to helping our patients feel dignity and helping them get invested in their own health. So that's kind of always a stance kind of in the background that should be operating in the background of the BHC's mind. And there's a wonderful resource that was put out by Peninti. If you have somebody that has active psychosis, there's this 5-minute first aid for psychosis. It's actually made for psychiatry to help psychiatrists incorporate CBT principles, CBT for psychosis, into their visits. And mind you, we are not expected as BHCs, or I guess I would take the position that we are not responsible for resolving psychosis with our 5-minute intervention for a first aid, with our 5-minute first aid for psychosis. But what we are responsible for is helping them with their overall health, helping them manage their lives, helping them improve the quality of their life despite the obstacles and barriers in their lives. And so again, they kind of have these principles, these kind of key principles to help psychiatrists remember that if you can normalize some of these active symptoms, if you can talk about the universality of some of the symptoms, that you are not alone, create a collaborative therapeutic alliance, building trust and rapport are really important. In this particular publication, they talk about focusing on a patient's life goals. And one of the first things I remember when I first read this, they have this really cool intervention about using a cue card where they reviewed the patient's life goals, listed some positive affirmations, talked about the patient's reasons for living, and having the patient carry that around and pull out that cue card with the affirmations, with some clear and realistic thinking about what their values are, the people that matter to them. It made an immediate impact on this particular patient's suicidal ideation and psychotic process. And so it's something that we use a lot in clinic. Winnet knows that we will often use the reminder card for their appointment, for the reminder to come back. We will paste something on top of it that talks about these affirmations, their reasons for living, their values and goals, and what they would like to share, sometimes related to the specific visit that we conducted. So those affirmative reminders that kind of talk about goals and value work is really, really important. And also the idea, the normalization, just kind of speaking to that, is that there is, the stress vulnerability model, right? And so we all know that under the right amount of stress, many of us might see a shadow out of the corner of our eye. Sometimes sharing that information with our patients is helpful because it helps people realize that these are a range of perceptual experiences that any human could experience under the right amount of stress and if they were predisposed to it. The other thing is providing, I included this is from the little article, this particular slide here that says a delusion is associated with a lack of real world knowledge. And so the recommendation is to provide some real world knowledge or provide some of that reality information. For example, a delusion that people can read a patient's mind it often happens. And so letting the patient know, like, well, there's actually, I'm letting you know that there's actually no data that would show that anybody can read complex thoughts of others. And when a patient has some level of insight, but also more importantly, trust, you can really see a decrease in their activation and in their defensiveness about the delusion. I've also really found it helpful. I remember one time we were working with a patient on medication adherence for hypertension. And he said he hadn't really been taking his medicine. He was very, very concerned that somebody was out to kill him. And it was concerning. The delusion was really getting in the way of his ability just to do his day-to-day things. We hadn't seen that kind of thinking occur. And his mom was with him, and his mom said, well, I remind him that that is his illness. And he looked at me, he said, is that part of my illness? And I said, yes, it is. That's part of the schizophrenia. It's helping your mind believe that somebody's out to kill you when you hear a loud noise, but that's actually not happening. And he was like, oh, okay. Well, he had so much relief that it was part of the illness that was creating this thought or delusion in his mind, and it wasn't actually happening. And again, like, that's the distress I'm hoping that people can tap into. He is really concerned that people were out to kill him, but once he understood it was part of his illness, providing that real world knowledge that he's being treated for an illness, it actually helped calm him down, and he was able to kind of keep moving forward with the things he needed to do. There's another resource that I have at the end that I'll be able to share with y'all that talks about, brief CBT for psychosis. And again, this is kind of some of these process-oriented things. Make sure you connect, kind of establish that trust. Anything you can do to build rapport is very, very helpful. Validating feelings. Again, this is from the psychiatry, so I like how they say, use humor, particularly the self-deprecating type. Which I guess is fine, but I think it's this idea about normalization and universality. I think our patients really often feel inadequate, feel a lot of shame. And so if we try to normalize the playing field, we are all human, we all struggle. I think that that's kind of where that comes from. But, understanding and breaking down a problem into chunks, that is extremely helpful. I often tell people when we do behavioral activation, sometimes we can only do a chunk of it. And that particular way of breaking things down, and we as psychologists kind of have that particular lens, can really be helpful. Teaching and practice, that's that drill and practice, which I don't know if that's a lot of what you all might do in visits, but we do a lot of that, in part because we are trying to help people self-manage. And if we can help them remember what they need to do, either through concrete interventions or through a cue card or through a handout or through just rehearsal, I think it's really helpful. So moving right along, these are some kind of specific interventions that you can do to help people when they are experiencing active hallucinations. And sometimes the trigger is very clear and it's very apparent to you. And so if you know what the trigger is as a BHC, you can figure out how to help manage that trigger, right? With like an ABC sort of formulation. But then you can also try to help the patient, try to figure out, well, is this hallucination getting in the way of your day-to-day life? Like, for example, the patient I brought up before about the blood pressure, it absolutely was. When the patient was able to remember to take his medicine, of course, he did very well. But oftentimes his psychiatric illness would get in the way. So one of the questions I like to ask is, are the voices or the things that you're seeing getting in the way of you checking your blood sugar? Or is it getting in the way of you taking your medicine? And sometimes they'll say yes. Sometimes they'll say, well, yes. And just actually this past week, we had a patient who came in and reported she was using her testing supplies to self-harm. So we were having to kind of manage that. Like, okay, well, tell me what's happening here. What is making you feel this way? And it really was related to depression, not related to diabetes. But again, those things just go hand in hand. So we have to make sure we're trying to address all of it. So this is a really kind of a good resource to help you understand how to intervene when you're hearing people or seeing people respond to stimuli. I know sometimes if it seems that somebody is attending to a visual hallucination, I might ask them, I'll stop what I'm saying and say, hi, are you looking at something? Are you seeing something? And they'll say, yes. I say, okay, can you describe it to me in a lot of detail? Can you tell me what you're seeing? And sometimes that focus on the hallucination, actually, what I often hear when I ask that is like, oh, it went away. Okay. And then we kind of move right back into our particular topic. So it kind of helps get us back on track. And then the patient kind of learns that maybe focusing in on it, and that's usually when somebody's on medicine. If somebody is not on medicine, then it's a little bit harder to do that. So that's another little tip, FYI. The other thing that has really been helpful for us when we have patients that talk about a lot of delusions or talk about some skepticism, paranoia, people being out to get them, people being out to kill them, is that engaging the distress or trying to find the theme of what they're worried about is and addressing that with one or two statements can sometimes be enough to help the patient calm down and focus on whatever you need to focus on. So sometimes patients can really go off on tangents about a delusion. And I will say, okay, what I hear you saying is that you're very, very scared. And I want you to know that I'm here to help you. And I want to try to help you with this particular issue today. Are you taking your medicine for, your psychiatric medicine? Are you taking the risperidol every day? Well, no, I'm not. So, well, maybe that's why some of these beliefs are bothering you. You can see the distress. So I try to do an in the moment relaxation intervention if I need to. And really addressing the theme, even though you may not be addressing the specifics. I also make sure I let patients know right away that I come in peace, I come to help. I am not part of a conspiracy trying to hurt them. And sometimes saying that up front is very helpful. It's only happened maybe twice where a patient has said, I don't care what you say, I still don't trust you, because of a delusional belief. Or perhaps because of, again, a lot of times delusional beliefs, like the mistrust of the medical system or medical providers, comes from negative and very bad experiences that patients have experienced. So again, you don't want to discount a delusion completely, because there typically is a kernel of truth that it came from. And so I can say, maybe you've had a very negative experiences before, but I really want to help you. And it's important to me that you know that. I want to help you, get better so that you can play with your grandkids. We hear that a lot, right? I want be able to live for my grandchildren, those sorts of things. Besides CBT and some of that reality testing that we can do, we also use ACT. And so some of the metaphors, which you may or may not have used with folks with psychosis, as passengers on the bus, leaves on the stream, or pushing against the folder. These are all really good interventions for psychosis. There's actually this book. I have it and have read it, and we use it all the time. ACT for Psychosis Recovery. And again, that particular book is really trying to help resolve and help people manage psychosis in the context of them trying to do other things to increase their quality of life. And so I don't expect that it's my job to make sure that their psychosis is completely resolved. I'm just trying to make sure that if they value their health, that they don't listen to voices or the negative feelings that are saying that they don't matter or that they're not important, things like that. So the one caveat I will say about using the metaphors is that, again, it's about hopefully the patient is being treated, they're on medicines, and if you can catch them in the middle of their injection cycle, then you're much more likely to get some traction with metaphors. I would caution the use of a lot of metaphors with somebody that's very thought disorganized or very, very psychotic. I have used ACT metaphors with patients that are kind of mildly psychotic, but not moderate or severe. So that's kind of, I guess, the caveat as well. The pushing against the folder exercise, I have that. It's a wonderful exercise that kind of talks about, which I don't know if you're familiar, where you hold a fold, I'm using paper, but you hold a folder in front of your face and say, this is what it's like to engage. When you're engaged in your thoughts and feelings, you can't really interact very well with the people around you. But so, we can kind of do that in the session, and it's very, very helpful to folks to kind of get that experiential experience with the metaphor. And I can share that as well. And so then, it might have come up when I said earlier, if they're mildly psychotic, I might try it, but not if they're acutely or severe. And so a lot of clinicians don't even really have a sense of like, well, what is like moderate psychosis, like some hearing some voices, but not completely. And so actually what we do in our clinic and what I have us do is track dimensions of psychosis symptom severity. This is the DSM-5 assessment tool, and it's clinician rated. So you are kind of rating what you see in the visit. But I find it to be very helpful, and especially in our particular setting where we're embedded, because we can get a real sense of if a patient has improved based on our own ratings of them on the dimension of hallucinations. So you can see how, like, for hallucinations, if the patient feels severe pressure to respond to the voices or is actively responding to voices and is extremely bothered and has a lot of high distress related to that, that's a 4, that's high severity, versus the patient might say, yes, I can hear voices, but I'm not listening to them. They're not bothering me. They're very quiet today. It's only happening once, maybe like right before I go to bed, and I don't even listen to them. That's a very different experience than 1 compared to the 4. And so this is kind of helps you track that, and you get that score, and then you can kind of look at that over time as you see the patient in primary care. Hopefully they're in longitudinal care with you. You can kind of see how their symptoms have adjusted, and sometimes that's really good feedback for that larger treatment team. Okay, I'm trying to leave a couple minutes. And so I guess the last thing really is the repurposing of interventions. So many of our patients, like I said, have already been exposed to lots of different information about mental health, about deep breathing. But I can't tell you how many times I have repurposed deep breathing for helping them not only with managing their anxiety, but helping them with their blood pressure, helping them organize themselves so they know which medicines to take at which time. Those sorts of things are really, really important. So if nothing else, part of what can really be helpful is being very concrete with your interventions, being very specific, being very behavioral. Being a SMART goal is a great intervention. We almost always do SMART goals with our particular patient population. Going to bed, even just that alone, going to bed at the same time and focusing on that for just a few weeks at a time can be very, very have a high impact. They're kind of simple interventions, but high impact interventions. And I guess the last thing that I really wanted to leave y'all with is that if it's if you don't know what else to do, doing medication adherence could be so key, so key. So making a tracker, helping people understand what medicines they're taking and what it's for is super helpful. Helping patients understand why they are taking their medicines and what they're trying to get out of their medication. Working on medication adherence is huge in this population. And if you can take an integrated lens, so not just think only about their primary care medications, but think about all of the medicines, you are doing a humongous service for a patient when you're thinking in that integrated fashion and helping medication adherence in that particular way. Okay, so let me see if I can get to my, I had like all these other things, but I'm going to get to my resources. This is like, some of the things that we already reviewed, but just a lot of other things that have come up. So that's another culture class. Anyway. These are some of the resources. I'll be able to send out some of these. I meant to do QR codes, but I didn't. But I can do that for y'all and send out the QR codes, especially with the 5-minute first aid stuff. The UW has awesome CBT-Psychosis training as well. A lot of it is free. Okay, let me see if there's like what, 1 minute, 2 minutes? Yes, okay. Somebody was asking, we have working at FQHC, they come to us for primary care, but they're not receiving other services. Yes. That is really hard. I mean, that's the key. I don't know, who was this? Melissa Fitzloff. If you are near a CCBHC, that would be our first thing. But if you're not, then, we can kind of discuss. There are typically other agencies that are community-based agencies that provide a lot of the similar services that CCBHCs do, but you really do need that psychiatry component, and then the ability to coordinate with them to do some of the things that I'm talking about. So I hope that this was helpful. I think we're out of time.
Yes, so helpful, so helpful. Thank you so much, Dr. Aguilar. I know we're at time. Just wanted to put up the presentation about final remarks. If you just give me one moment, and then we'll end.
This was amazing. I just want to say thank you so very, very much. Thank you.
Oh, you're welcome.
Thank you.
Yeah.
It was
Yeah, and
amazing. Thank you so much.
Yes, please email me or, get in touch with anybody at PCBH. They can get with me as well. Thank you guys. Thank you so much. I appreciate that.
So just a few closing remarks here. So thank you everyone for joining us today. And thank you again, Dr. Aguilar. That was amazing. So just a quick plug for the conference. The conference is coming up in October, and all the sessions will be recorded and posted to Integrated Care Learning shortly following the conference. And then our next PCBH SIG meeting date is August 2nd, 2023. And it will be a Wednesday, and that's 1 o'clock Eastern time, 12 o'clock Central, 10 Pacific. And like I mentioned earlier, our topic will be the marriage checkup in primary care. And then final plug for mentorship. If you want to sign up to be a PCBH mentor, we'd love that. Just click on that link there and complete the application. And I think that is all. So thank you all so much for joining us, and then we'll see you in a few months.